All right, for shortness of breath, now let's talk about the patient that's in acute distress or the patient that needs intervention, acute resuscitation. Let's go through our differential and talk about what interventions will do. The big things we talked about, especially patients with abnormal breath sounds, are COPD, and I'm going to lump asthma there together as well, CHF with pulmonary edema, pneumonia, and the pneumothorax we'll talk about then chest pain. Under pneumonia, we'll have bacterial as well as viral, which includes COVID. So we did our ultrasound, the lungs are completely clear, the patient's really wheezing, and they have a history of COPD. Let's talk about how we manage them. First of all, if they need respiratory support, the mainstay of non-invasive respiratory support for COPD patients is non-invasive ventilation. We're going to put them on a BiPAP, some positive pressure to buy us some time. Secondly, we need to resuscitate them with albuterol and Atrovent. Not just 1 unit dose, we're going to give them a lot of breathing treatments to try to get them opened up quickly. My standard go-to is at least 4 breathing treatments to start. So what I do is 2 of the combined albuterol Atrovent. The trade name is Duoneb. I don't get any money from them, I promise. But I do 2 Duonebs, which is going to have albuterol and Atrovent in it. At Magnolia, you order it by the ml, which is kind of silly, but 6 mLs is 2 unit doses of Duonebs. And then on top of the 2 Duonebs, I do 2 standard doses of albuterol. Standard dose of albuterol is 2.5 milligrams. So to do 2 of those, I'm going to order 5 milligrams. That's going to give me 10 total milligrams of albuterol because I did the 2 Duonebs plus the 2 albuterols plus a full milligram of ipratropium bromide or Atrovent. I'm going to get the breathing treatments going. If they need the assistance, I'm going to get them on non-invasive support, and then I'm going to give them steroids. I typically do Solumedrol is my steroid of choice, but get this patient some kind of IV steroid. Classically, we've done 125 of IV Solumedrol. More progressive thinkers are realizing that that's far too much. You could probably get by with 60 milligrams. Talk to your attending. Whatever dose your attending wants, just make sure we get steroids on this patient early. And then there's some evidence for IV azithromycin. Now, azithromycin is an antibiotic. It's a macrolide. We know that it does not have great streptococcal coverage anymore because it's been overprescribed so much. However, there has been shown benefit in COPD exacerbations, and the thought is macrolides have some anti-inflammatory benefit, so maybe it's the anti-inflammatory properties that give it the benefit and not the antimicrobial properties. Regardless, when I get a severe COPD patient, I typically will add 500 milligrams of IV azithromycin. And then knowing if I see pneumonia, I need to add a beta-lactam to cover streptococcal pneumonia as well. This is my standard resuscitation for a COPD patient. I try not to intubate them if I can. We resuscitate with non-invasive ventilation, breathing treatments, steroids, IV azithromycin. Furthermore, COPD patients are frequently dehydrated. They've been breathing very quickly. You lose a lot of fluid through insensible losses when you breathe. And so typically they will be dehydrated. So my run-of-the-mill COPD exacerbation, I usually will order them 1 liter of IV fluids. My go-to IV fluid is lactated ringers. You can do normal saline, talk to the attending, see what they want. This is my workup though for resuscitation of a COPD patient. Non-invasive ventilation, Duoneb, steroid, IV azithro, and then I give them some fluids. Now when we talk about our asthmatic, my workup is very similar. The difference here is I'm not going to do the IV azithro for an asthmatic. The proven benefit there was for COPD patients. What I do though is 2 grams of magnesium, especially if this is a sick patient that I'm putting on non-invasive ventilation. I'm considering admission. I'm going to do IV mag. There's evidence for IV mag avoiding intubation in asthmatic patients. So that's going to be the difference for me. For COPD, you're going to do the IV azithro and not the mag. For asthma, you're going to do the mag and not the azithromycin. So next, we'll talk about our patient in CHF. These come in 2 forms. The first form is just a little fluid overloaded, not acute distress, some crackles on exam, some pitting edema, but they're talking to you in full sentences. They ate at the Golden Corral, they drank some extra sweet tea, they haven't been taking their Lasix because they're peeing too much. That patient probably just needs diuresis. The rule of thumb for this patient, if they're just fluid overloaded, that's all that's going on, they're not circling the drain, is we typically double their home dose of Lasix. Now, to be honest, we do more than that because, for example, 40 milligrams of oral Lasix, that's equivalent to 20 IV. So giving 40 IV is doubling 40 oral. We double the number frequent times. If they take 40 milligrams at home, a lot of times I'm giving them 80 milligrams of IV Lasix. Don't be afraid of giving too much Lasix. If the patient's there, short of breath, and they're clearly fluid overloaded, hit them up with a strong dose of furosemide. Again, we're going to double the home dose. Technically, giving the IV, giving the same number is doubling the dose, but we double the number. We get aggressive with the Lasix. There's a second type of CHF exacerbation that we frequently see, and this is different from your just run-of-the-mill fluid overloaded patient. This is something called sympathetic crashing acute pulmonary edema. This patient comes in looking terrible. They have beelines throughout both lung fields on exam. They're struggling to breathe. They look peri-death because they are peri-death. The problem here may be fluid overload, but their biggest issue is this huge endogenous surge of catecholamines, such as endogenous epinephrine, norepinephrine. This clamps down their splanchnic circulation. When that happens, that increases your circulating volume by about 30%. If we can get them to relax, if we can break that sympathetic surge, fluids will redistribute and they'll start looking a lot better quickly. Now, the mainstays of these patients are beelines diffusely on exam, severe shortness of breath, and a very high blood pressure. If they're hypotensive with these findings, it's cardiogenic shock and they're not looking good. But when they're hypertensive, and I'm talking, you'll see systolics 220, 230. When they're hypertensive, this is an easy patient to manage. The first thing you want to do, get them respiratory support in the form of non-invasive ventilation. We'll do a whole lecture on non-invasive ventilation another time, but get them on positive pressure ventilation to support their respirations while resuscitating them. Secondly, you want to get them on a high-dose nitroglycerin drip. Now, for chest pain patients, we frequently start at 5, 10, maybe 30 micrograms per minute. That's for like a chest pain nitro drip. For SCAPE, you need high doses. Usually, most attendings here will start at 100 micrograms per minute, and we'll titrate in increments of 50 micrograms per minute. So we'll start them on 100 mics a minute, and if that's not working, we'll add 150. If that's not working, we'll go to 200. Usually, by about 400 micrograms a minute, you'll break the sympathetic surge. Occasionally, you'll have to go higher than that. Don't be afraid of the nitro, though. As an intern, when you have one of these patients, get an attending, get an upper level to help you, because you can fix these patients really fast. And these patients, their heart is dying. If you don't fix them really fast and their blood pressure tanks, now they're in cardiogenic shock, which is much, much more difficult to take care of. So we talked about COPD. We'll go back over it. We're going to start them on non-invasive ventilation. We're going to give them breathing treatments. We're going to give them steroids. For COPD, we are going to do the azithromycin. And for COPD, we're going to give them IV fluids. The different in asthma is we're not going to do the azithro, but we are going to give IV magnesium. For CHF, again, if they're just fluid overloaded, we're going to give them a diuretic. We're going to probably furosemide, double their home dose, double the actual number. Don't be afraid of furosemide. If they're sympathetic crashing acute pulmonary edema, they look terrible. At that point, we're going to get aggressive with non-invasive ventilation. We're going to give a high-dose nitroglycerin drip. And you know, if you get to the point where you've broken the sympathetic surge and you can't wean the NIV, you can't wean the nitro, then at that point, consider diuresis. The next type of patient we got to talk about is our patient with pneumonia, especially if they're in severe respiratory distress. Now, we mentioned non-invasive ventilation. It's great for COPD, it's great for SCAPE or severe crashing acute pulmonary edema. However, for pneumonia, that positive pressure is going to pack down those secretions and won't allow your patient to cough and may impair secretion clearance. You may have no choice. If they're really distressed and you're concerned you're going to have to intubate soon, sure, you got to reach for the non-invasive ventilation, but if they just need a little help, mainstay of support for pneumonia patients is high-flow nasal cannula. We have a couple different devices at Magnolia. Just ask your respiratory therapist, I need a high-flow nasal cannula or a vapotherm, and they'll get this set up for you. These are nasal prongs. It gives high flow of heated, humidified oxygen to help the patient breathe. It gives them a little bit of PEEP. It gives them some dead space washout. It gives them some support. If you can get by with that on a pneumonia patient, you're going to have better outcomes. New England Journal of Medicine 2015 Plurality Trial, prospective randomized controlled trial, high-flow nasal cannula versus non-invasive ventilation. Look it up if you want to read more. Secondly, we've given them some support. We need to evaluate their fluid status. Pneumonia patients are tough because if they're septic and they're dehydrated, they're going to need a lot of fluids. But if you flood them with fluids, you're going to flood the lungs. You'll have a lecture on sepsis. What I will say is, on pneumonia patients, if their lactic acid is greater than 4, or if they're hypotensive, by rule, you're supposed to give them 30 cc's per kg. If you're concerned that's going to worsen their pulmonary status, document that. And document that you're just giving a liter at this time because you're concerned that third space in the lungs, that's going to make them worse. Be conservative with your fluid management on pneumonia patients. The next thing that we're going to need to do is antibiotics, obviously. 2 big groups of bugs that we got to kill are our typicals, so like our streptococcal, and then our atypicals. So like your H flu, your Legionella, your Mycoplasma, stuff like that. For your typicals, beta-lactams work really well. The beta-lactam that I like is ceftriaxone. It's 1 gram once a day. You can dose that and you've got 24 hours of coverage. But again, pretty much any beta-lactam will cover your typical pneumonias. The other group that you have to kill is your atypicals. The thing that I like for atypicals is azithromycin. This is phenomenal for killing atypical bacteria. It used to have streptococcal coverage, but there's a lot of resistance because it's been overprescribed. This is my usual go-to cocktail first for community-acquired pneumonia. Now, there are some drugs that kill both typicals and atypicals. You'll see a lot of attendings ordering doxycycline. Mono coverage. It has typical coverage and it has atypical coverage. There's a little bit of debate among practitioners nationwide about the streptococcal resistance to doxycycline. I will not get into it. Most antibiograms don't tell you doxycycline, they tell you tetracycline, and so we're extrapolating. It's a whole thing. Anyway, especially like a pneumonia that looks pretty good, I may do doxycycline mono coverage. It's only 1 drug they have to take. It's also a reasonable alternative. Another drug that kills both typicals and atypicals is Levaquin. The problem with Levaquin is it carries a lot of black box warnings. It's not great for elderly patients. It's going to increase the chances of future aortic issues, future tendon issues with your younger patients. So typically I don't do Levaquin unless it's the only option that I have, unless I can't use anything else. These will cover atypicals and typicals. Now, these are all for community-acquired pneumonia. If you have a healthcare-associated pneumonia, there's a couple of more bugs that you have to kill. Pause it and think about it. See if you can come up with the other 2 bugs we have to kill. I'm going to tell you now, though. The 2 are Pseudomonas and MRSA. So the things that kill Pseudomonas is, I'm going to use trade names because it's what we remember. 1, you can do Zosyn. This is the piperacillin tazobactam extended spectrum penicillin that has pseudomonal coverage. Your other option is Levaquin. Again, we said we want to try to avoid Levaquin if we can because of all the black box warnings. You can also do Cefepime. This is a 4th generation cephalosporin and it has pseudomonal coverage, and this is actually the drug of choice for healthcare acquired pneumonia because it gets typical coverage, it gets atypical coverage, it gets pseudomonal coverage, and head-to-head, Zosyn versus Cefepime, when combined with vancomycin, Cefepime has lower rates of kidney injury. So our typical healthcare-acquired pneumonia, our cocktail is Cefepime, and then you have to decide if you need to cover for MRSA. They have a history of MRSA. If they've been hospitalized recently for a skin and soft tissue infection, the dependence of the current MRSA prevalence in the community determines whether you need to cover MRSA. I always cover MRSA for healthcare acquired, especially in the ER because I don't want to miss on that first dose. And typically what we'll do with that is vancomycin. You want to do 15 to 20 milligrams per kilogram. Make sure you're weight basing that so you don't underdose your patient. Some other options if you're treating MRSA on the outpatient, just because we're talking about it, Doxy. It's a great antibiotic. It actually has MRSA coverage, and then Bactrim is the antibiotic that has the highest coverage typically of MRSA if you're going to treat MRSA in an outpatient setting. These are your bugs and drugs. If you're covering your typicals, if you're covering community acquired, make sure you cover your typicals and your atypicals. I like ceftriaxone and azithromycin. It's once daily dosing. I can order it, and if they hold an ER for a while, I don't have to worry about ordering a second dose. You can do monocoverage with either Doxy or Levaquin. Doxy, if they're a pneumonia patient, looks pretty good. I frequently will do Doxy. Some of our attendings will do Doxy on everybody, and that's okay. Talk to your attending. And then Levaquin, we really try to reserve unless we don't have any other options. If it's healthcare-acquired pneumonia, make sure you're killing Pseudomonas as well. Cefepime is going to be your mainstay of treatment for pseudomonal coverage for pneumonia. And then I always cover for MRSA as well. Vancomycin IV is the easiest way to do that. The other thing we have to talk about with pneumonia that we're seeing a resurgence of is COVID pneumonia. There's a lot of drugs, a lot of things that have come out to treat COVID. There's not great evidence for anything except for a few things. One, for respiratory support. Based on that Florali trial, we extrapolated that and we were putting a lot of COVID patients on a high flow nasal cannula. However, we were showing that they seem to do better on non-invasive ventilation. My thought process behind this is we were taking patients that were in too severe of distress and putting them on high flow nasal cannula. If they're in severe distress, go with non-invasive ventilation. If they're just so-so, try high flow nasal cannula. So again, don't wait until they're circling the drain and then put them on high flow nasal cannula and you think you're going to do something. Give them some respiratory support to try to avoid intubation if you can. And then two, if they are hypoxic. If they are hypoxic, you want to do Decadron. You want to do a steroid, typically at least 6 milligrams. There is a proven mortality benefit with Decadron in COVID if you are hypoxic. However, the initial trial demonstrated a trend towards harm in giving steroids if the patient wasn't hypoxic. So if they're not hypoxic, don't give steroids. More and more evidence is coming out to support that. If we give steroids too early in COVID, we are going to cause harm. So if they're hypoxic, they get steroids. If they're not hypoxic, do not give steroids. This is the mainstay of treatment for COVID pneumonia. High flow nasal cannula, non-invasive ventilation, and then when they're hypoxic, give them Decadron, a lot of supportive care to try to get them through this nasty virus. Obviously, there's a lot more causes of shortness of breath than just those. Those are the big ones though. Those are the mainstays of your management. Try to identify these, try to manage these appropriately, and you'll hit the ground running on July 1st.